Hello and welcome. I am Dr. Jim Weiss, and happy Chinese New Year. While COVID-19 has become the leading cause of death in the USA, back pain is the #1 cause of disability worldwide. 16 million people suffer with chronic back pain in the USA alone. And despite many different types of treatments to the spine, there seems to be no great solutions or consensus about treatment. This, coupled with the narcotic drug abuse epidemic and other social and economic ills related to the problem, this demonstrates the scope of this huge problem. So we welcome innovation solutions to chronic spine pain. Dr. Pauza will be sharing his research and clinical experience of this new and exciting procedure that advances the treatment and thinking about spine care called Discectomy, for which he has treated numerous patients. We all know someone with back pain, and we also realize that one can get 10 different specialists from 10 different specialties, including a chiropractor, a physical therapist, a spine surgeon, acupuncturist, sports doctor, stem cell specialist, etc., and get 10 different opinions what to do for the same exact condition. Who is right? I welcome Dr. Pauza, who is an internationally recognized board-certified physical medicine and rehabilitation physician and surgeon and innovator in the area of minimally invasive spine procedures and also a non-surgical approach. Dr. Pauza, hello. How are you?
Hi, well, thank you. I'm honored. Thank you very much.
So, Dr. Pauza, tell us, what is the Discectomy procedure?
Well, essentially, it will cause you to recognize that it fits every issue with low back pain or neck pain that you've come across in the past. It's a procedure that addresses the problem. We know the problem is not pinched nerves, but instead it's a disc that's torn, that's leaking, causing inflammation. Historically, I was taught that it was a pinched nerve. That's not the underlying problem. Discectomy targets the problem, the tear within the disc, the annulus fibrosus. It seals it.
Dr. Pauza,
yes.
Let me help you. I put up a slide. Do you see the slide?
Yes, that's
okay.
fabulous.
Is that helpful?
Yeah, thank you.
Okay.
Okay, so the disc is simple. When you're talking with your patients, just think of it this way. The disc is 2 parts. It's the center gel. That's an amorphous gel. It's dead. It's just a gel. It's a tissue. And then it's the outside rings. It's 22 to 25 rings. Every sensory nerve resides only within those rings. And every disc pathology that you can think of, and it's rare that I could say the word every, but every disc pathology that you can think of originates because of a defect of the annulus fibrosus. And it was called the annulus fibrosus because it reminded early investigators of the annular rings of a tree when they cut a tree down. Think of a disc herniation, bulge, protrusion, degeneration. All of it originates when the annulus fibrosus tears.
So you've been told that you have a disc fetish, that you're...
Yes.
Because you believe that the spine conditions really initiate at the disc level. That's the primary problem, right? In many cases.
Well, right. The disc is it's a 3-joint complex. So we have the disc, that's the center joint, and then we have the facet joints. And indeed, I take into consideration that pain can come from facet joints and from the muscles around the discs and the ligaments, but with deep, intense research, we can see that it originates by and large from the disc itself, with those rare exceptions where there might be a shear force tear in a facet joint capsule. So most pathology that you can think of in the spine, except for cancer or trauma, originates from a torn disc.
How did you come up, changing the subject, how did you come up with arriving at using fibrin to seal the disc?
Well, I started doing research in neurosurgery when I was 14 years old at Penn State. And I recognized that the surgeons there wrote the books. And I I saw that the patients weren't reliably getting better. The surgery was perfect, but the patients weren't better. And so then I thought the paradigm must be wrong. It must not be mechanical. And so then I sought ways to seek the answer. And around the world at the same time, other researchers before me recognized symptoms are not caused by pinching a nerve. We can pinch a nerve and it causes no symptoms. But if there's associated inflammation, it causes symptoms. And so for that reason, I started early with stem cells about 25 years ago and other biologics. But remember, it's a leaky disc. So it needed to be something that would stay within the disc. And the most natural solution was fibrin, is because fibrin is what actually seals our cuts and heals our cuts and causes skin to turn into skin after it's cut. And it does the same in the disc.
So is it fibrin alone that's needed, or other things that, let's say, work on other areas, like platelets also work with PRP and stem cells? Do you advocate using your procedure alone or with stem cells and PRP?
Well, I think we assumed that there'd be value with adding fibrin with PRP, platelet-rich plasma. And so we did a controlled study following both groups, and statistically significant improvement with pure fibrin. And that surprised us. And it may be because the binding of the fibrin was not interfered with by anything. But having said that, we're still studying other biologics in the disc only if we first seal the disc with fibrin so that whatever is put into the disc remains within the disc.
So when I came to your clinic, you actually showed me the fibrin, and I was playing with it in my hand, if you remember, and it feels like rubber cement. So you think the main effect is mainly a sealant effect, correct?
Well,
or you're not sure? We're not sure.
We spent a lot of money, and personally our research has spent over $15 million just into that question as to what's happening. And we know that indeed the fibrin, it's made up of, we'll simplify it by saying it's two components that come together when we cut ourselves. The two components would be prothrombin and fibrinogen, and together they make fibrin. And that seals the cut. And so the disc is returned to normal strength, normal mechanical strength within less than 1 hour. And that's not the important part. To me, though, the important part is that over time, we've discovered that the fibrin is converted, if you will, it stimulates new disc growth. And because of a placebo-controlled study done at the University of California, San Francisco, it showed that fibrin causes degenerated, damaged discs to be, let's just say, turned into young, healthy discs. And in the control group, out of 220 discs, no control discs were healed or changed.
Before we get into your research, just a general question for you. Do you think it works better than spine fusion or disc surgery, which is what the majority of patients are getting for, severe disc herniations and degeneration?
And to me, it's a mystery. I don't know why, and I'm glad we have medical directors in the audience as to why they're allowing fusions. The fusions were developed in 1911 to treat instability caused by cancer, trauma, period. And then over time, the surgeons cause it to evolve into treating pain. The research is very clear from around the world that if we fuse a segment, it transfers those forces to the adjacent segment, potentially causing accelerated adjacent segment degeneration. We call it the domino effect. And then likewise, if we do a discectomy, we're simply weakening the annulus fibrosus, predisposing it to accelerated same segment degeneration, which then ultimately leads the surgeon towards fusing that segment. So we call it the annuity plan. I work with a lot of spine surgeons, and I know in the waiting room, in the lounge, they joke about it. When they do a discectomy, they call it the first part of their annuity plan, and that pays for their children's high school tuition. And they know that 3 years later, that same patient is likely to come back And they'll come back because they'll say, oh, this doctor was conservative. They did not fuse me the first time. And then the doctor will say, this time it looks like a discectomy is not your answer, but your only solution is a fusion, so I will fuse you. And it caused my hospital to become too profitable, in my opinion, which caused me to be outspoken.
And we also know from the research that it's not clear whether it's the surgery or just the effects of aging and time that those adjacent discs degenerate. It's just correlated with it. So we don't know, but it's going to happen either way. So you're going to end up with a degenerated disc.
Yes.
Question for you. So how does the what's the FDA issues with this procedure, especially vis-a-vis all these new procedures with PRP and especially stem cells? Are there any FDA issues?
Well, luckily, we intentionally don't want this to be confused with stem cells because it's not. The FDA approved the Fibrin. It's made by both Johnson & Johnson and Baxter in the distant past. And for every place that it was submitted for use, it was accepted by the FDA. And the first place was the spine to seal the dura that was injured by surgery or trauma, to correct the spleen with blunt trauma, for facial reconstruction, and for a whole host of lists now. The Fibrin is approved for FDA use. So this is a common off-label use of an FDA-approved drug analogous to epidural injections of steroid. Many insurance carriers authorize the use of epidural steroids, and epidural steroids have not ever been approved for FDA use, and the FDA sent out a black box warning against using epidural injections of corticosteroid. Yet it amazes me that insurance carriers still allow it to occur.
So it's a costly procedure, as I understand it. You hope in the future that the insurance will cover it. Is that your thinking on it?
Well, we have several insurance companies meeting with us now that want to include it because it is not a costly procedure compared to what the alternative is.
Okay, gotcha. Can you just walk us through just briefly a patient that you treated, what type of treatments they got before and how they responded to your
Yeah, well, so we'll just say a general patient, it'll be a patient that'll be in a recent study that we did. So in a study that we did, we followed 373 patients prospectively for 24 months, okay? And every patient had to have failed epidural injections, chiropractic, physical therapy, and either stem cell injections through one of these noted stem cell centers in Colorado or elsewhere using their protocols, or spinal fusions or discectomy. So in other words, these were patients that were doomed to fail. They've all had pain for over 5 years duration, and they were entered in the study. They were followed prospectively. So we simply did the procedure, and the procedure is a two-step procedure. A very small needle is directed into the disc, and it injects a trace amount of contrast with antibiotic. That identifies the tears of that disc. And then we inject the fibrin into those tears. And we do each of the discs in those regions. These patients were followed, and we demonstrated statistically significant improvement in every outcome tool. And because we thought that the study would be controversial, we used the only outcome measures endorsed by the American Academy of Orthopedic Surgery. That's called the OBIRD registry. And so having said that, they were followed independently, prospectively, and they had statistically significant improvement with pain, function, disability, quality of life, mental health, everything.
When you did your annulogram and you found it to be a leaky annulogram, were those annulograms painful or were they just leaky? In other words, did you seal the ones that were leaky or the painful ones, or both?
Good question. For scientific reason, we know that the appearance of a disc matters not. Everyone knows that. And that's one of the big fallacies that happens today in medicine, is that people look at the MRIs and they see bulges. Well, we know based on the New England Journal of Medicine, July 17th, 1994, they showed that asymptomatic individuals are more likely to have bulge discs than not. Anyway, having said that, because of that background, we tested each disc in that region with an angiogram, and we intentionally didn't seek to provoke pain because that mattered not. And then if there was a pathology, a tear, then that disc was simply injected with fibrin. And on average, 3 discs were torn and repaired at that time. The procedure takes less than 30 minutes. The recovery is 30 minutes. And we want the patients to be back at work within less than 1 week.
You know, one of the things that impressed me, what you told me privately, was that you worked on patients that already had fusions. You did the angiogram, which came back positive, and you injected fibrin and you got great results. Is that true?
Yeah, we have a large group of patients who've underwent multi-level fusions. And again, the fusion made no sense to me starting when I was 15 years old observing them, because it's a chemical thing. It has nothing to do with that. Just think about that. It's made up. So you're exactly right. And so I simply did angiograms of every disc that was fused, because when they fuse a disc, they leave the annulus there. We saw the leaks, we addressed them, and those patients that were fused and had pain for some of them up to 20 years are today without symptoms. It's made to be a one-time treatment because it regrows the disc. It's not made to be one of these other repetitive treatments that patients come back and back for.
When do you expect your research to be published that we can review?
It'll be published within less than 6 months.
Cool. Do you have anything else you want to share, Dr. Pauza?
Well,
did I cover most of it?
The important thing is luckily I think insurance carriers are recognizing it. So just this past week, we met with 2 of the larger insurance carriers in the United States because they saw the preliminary results of the study. And I'm glad there's pharmaceutical companies attempting to make sealants. They're not able to use fibrin because fibrin is something that is very controlled, and we want it so that it's only limited to use by physicians that are trained, because stem cells went down a bad direction, in my opinion. They may have value, but they're being used by everyone inappropriately. Fibrin is the only thing that I'm aware of in regenerative medicine that is patented and protected by Congress, so that it can only be used in the spine by physicians who are specifically trained and licensed to use it. So therefore, we're expecting to have reproducible, high efficacy and safety based on what we've seen in our multi-center studies.
Dr. Tomasak, I think you might have a question. Do you?
I don't know. I mean, a little bit of it, the angiogram, I now understand a little bit better. At first, I was going to ask about how we made it, consistent between interpreters. Similar to discogram, we have all those issues with interpreter bias and that sort of thing. It doesn't sound like we have that issue with the angiogram. So, Dr. Pauza, just for clarification, the angiogram is more to show these are the annular fibers. We're not asking for pain. It's an anatomic condition that we're just going to seal because we know that's what we're fixing. Is that
yes,
a correct understanding?
You're very astute. You hit the nail on the head, because I was involved with determining what's a normal discogram and what's not, using pressures, etc. And it's very subjective, even though they think it's objective. So you're exactly right. An angiogram is straightforward. A small needle into the annulus fibrosus. If there's an annular tear, then that's what it is. And it's easily seen from across the room, and address each disc in that region because we know that the procedure is safe. And that led us to these results. And there's no reason to have any subjectivity with the test. It's very objective. It's relatively pain-free, and it eliminates those problems that are caused by discograms brought up by Eugene Kerji and others. Good question.
All right, and the other question, I guess, was kind of a twofold one, but I'll keep it all in the same. Your future research that you're going to be looking at, what type of random controlled trial are you going to propose or possibly get in the future so that we can compare to, I guess, a placebo type of a quote saline injection maybe, or some other condition that we can prove that there's a little bit
Good
more
question.
efficacy?
Yeah.
And then the second part would be comparing it long-term goals to just the natural course of healing of a disc injury that resorbs on its own over the 4 to 5 year time frame. So
Yes. And so quite simple, and it'll be similar to the protocol I used that won the NASA Outstanding Award for IDET, and that's where I treated a group and I didn't treat a group, and nobody knew who was treated because everybody they went in without knowing, and then we'll follow those people over time. But because of the pretty dramatic improvement, statistically significant improvement in these patients that are treated. And by the way, these are the worst of the worst patients. We didn't seek patients, or as they say, cherry pick patients that we hope to get better, but instead we did the opposite. We sought patients that failed everything else before they were allowed to enroll, and we still demonstrated such dramatic sustained improvement. And the majority of patients had pain for over 10 years duration, so it wasn't likely regression to the norm, but we'll just do that. We'll have one group be treatment, the other group be non-treatment, and follow them. Having said that, that's never been done for artificial disc or fusion, which is allowed on a regular basis, which again still amazes me, and it just causes me to think it must be something political that they would allow that to occur without ever subjecting those to true randomized studies.
Thank you. Dr. Yen, do you have any questions for Dr. Pauza?
Yeah, I have one question about randomized controlled trials, but I think Kevin asked the question, so I'm going to ask another question. And before I do, Dr. Pauza, I just want to let you know my background is in cardiology, so I certainly have a lot of experience with randomized clinical trials for medical devices. And because of the years I spent in industry, I also know that pricing a product is crucially important because there's a graveyard full of wonderful, innovative technologies that just never saw the light of day because insurance refuses to pay for it.
Yes.
So my question to you about that is, this is out of my personal curiosity, really, because as a medical director for Cigna, I'm strictly cardiology. So I'm sure someone in Cigna is looking at this, but it's not me and it will never be me. So this is out of personal curiosity is, does this involve extra cost, or is it just the price of the fibrin and then you bill the patient for a spine procedure as you do now, injecting steroids or whatever the existing therapy is?
Okay, good question. With the two medical directors that we met with last week of major companies, they both said it's underpriced for what it is. But anyway, having said that, so we haven't come up with a cost because we know that comparatively, it's compared to a multi-level fusion. And a multi-level fusion is over $100,000, obviously, in addition to the follow-up that goes on after that. And so we'd like the cost to stay under $15,000 total. And that includes physician, hospital, et cetera. And that's where we've kept it. We've kept it below $15,000 total.
Okay. Anybody else have any questions for Dr. Pauza?
I don't have a question, but just along that same line, Dr. Pauza, I think the pricing strategy of new procedures or technologies has a lot to do with the economic aspect. I think, a lot of it depends on the prevalence of the disease that you're trying to treat, and also the alternative existing treatment and how successful and how efficacious that is. And so having worked in industry, I know that the pricing strategy a lot of times doesn't have anything to do with the clinical medicine aspect of the therapy. It has a lot to do with the economic aspect.
Well, that's good advice. And one of my hallmarks was, and you'll find this interesting, I was one of the co-founders of one of the busiest fusion hospitals. I call it a fusion hospital, but it's a spine hospital. And they were pricing my procedure outside of what I wanted. And in other words, the surgeons did not want this at the hospital, so they simply increased the facility fee. It started at $5,000, and within a year it was at $50,000, and it did not stop any patients. And then having said that, they simply said, Dr. Pauza, we'd rather you not do the research or the treatment at this hospital. So I did it at a private center where I could keep the cost below $15,000. And my patients come from all continents, and the outcomes speak for itself. 80% of our patients are there from referrals of other patients. But your comment on pricing is good. It's well received, and it is something that has been paramount to me to keep both the quality high, the safety high, and the cost low.
Dr. Yan, you have any other questions? I didn't mean to cut you off.
No more questions. Thank you.
Okay.
Thank you for your question.
Dr. Pauza, thank you very much for your time and energy. We really, go ahead.
So now remember, my background's not medicine, so bear with me here.
Yes, sir.
But if there's a tear in the annulus, and if the fluid, my understanding is if the fluid leaks out and the disc becomes desiccated,
Yes.
and you use fibrin to heal the disc, does it rehydrate?
Yes. Remember that the discs are nourished not through blood vessels, but through end plates above and below. And this is the key. If I could say one thing that's the key, is that center gel is perceived as a foreign substance by the human body. So when it leaks through the annulus, it'll cause inflammation and the autoimmune response there. And if it leaks out of the annulus onto the spinal nerve, it causes sciatica, radiculopathy. So that's the key thing. The gel is a foreign substance. So if we can keep it in there, the body reproduces it. It's an ongoing, and especially if a person has symptoms, we know the gel is being produced, because otherwise the person will not have the symptoms of that gel leaking on the neural tissue. And so, yes, it's reproduced. And some centers are erroneously focusing on making an artificial gel, if you will, but there's no nerves in the gel. All the nerves and all the pathology occurs within the confines of the annulus fibrosus ring.
We have a client now that had a discectomy. And as you said about the segmental dysfunction, that's exactly what's happened to her.
Yes.
She had the surgery and then a revision surgery. And over the last 2 years, it's gotten progressively worse. Now she has like an anteriolethesis. They looked for performance syndrome, and that was negative. One doctor recommended an extreme lumbar interbody fusion. 2 other doctors recommended just pain management. Would this procedure be something that's still appropriate for her at multiple levels?
Well, the majority of patients, and again, I base this on comparing my MRI, which is a 3 Tesla MRI with an angiogram. The angiogram has far greater sensitivity. And so patients from around the world will not know what the cause is. And then likewise, we'd find the tears, address them, and the patients are better. Many pro athletes that you know and see on a monthly basis have been treated this way. So this is an ethical question that I have, and I need help with this ethical question. Two of the prolific surgical device companies that make devices to perform microdiscectomies, minimally invasive microdiscectomies, want to license Disceceel so their doctors can use Disceceel. And I welcome that. But my concern is that our research is very clear that out of several hundred patients, we've never seen a patient with one level involved. And so indeed, it'll fix that disc, but I'd like those doctors to also look at the other discs that are adjacent, because I would bet the farm that 1 or 2 other discs has tears, and I wanted to maintain the high outcomes that we've been having. So we're talking with those surgical device companies who desperately want to do this procedure. currently they're flying their patients to Texas or New York, and I'm treating these patients immediately after they undergo the microdiscectomy, because it's common sense. If you do a microdiscectomy, you're leaving a big hole in the annulus fibrosus. It doesn't belong there. And this addresses that. It causes that to turn into normal disc tissue. And so, it's a matter of, do we have those doctors do it without getting thorough training? I'd like them to be trained so that they're taught to test each of those discs adjacent to the discectomy level and have that patient be treated very well.
I just had one more question. Is this something that most major health insurance companies are now covering?
We've not opened it up to insurance. I'm sorry about that. We've spoken with a few of them that want to cover it now. And so now the challenge is to teach the physicians, because again, I don't want to go in the way of stem cells. We have excellent physicians who offer regenerative medicine with stem cells or PRP, and others that are not as good. And so I really want this to be available only after everything's ramped up. We're in that process now of selecting. I've got several hundred spine surgeons, non-surgeons on the list who want to be trained so that we can roll this out this year. The insurance companies desperately want it because it's very clear that the fusions are a failure.
Dr. Pauza, we're running out of time. I just want to say this. Thank you so much for this excellent presentation. And this innovation, this is a brand new, brave new world, a totally different way of treating spine care. I think you're really on the forefront of something amazing. And I'm not just saying that because I'm your host today. I really believe it. I really believe that this is going to be part of the future of spine care, a big part. So thank you so much for coming.
Well, I'm humbled because I know my audience, and I'm very humbled to be allowed to participate. Thank you very much. And Jim, thank you very much, especially you.
Yeah.
Thank you, sir.
Thank you.
And thank you. And
thank you.
Have a wonderful day. And maybe we'll have you back again after you have your research published. We could talk about it further.
Wonderful. Thank you very much, Colin.